Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's program. On today's program, we're continuing with our new series on the spinal impairments, and we're focusing specifically on the analysis of loss of motion segment integrity as one of the important impairments for loss of function of the spine. And today I have a fascinating case for you. It involves the lumbar spine. I think it demonstrates a very creative use of the loss of motion segment integrity as a permanent impairment for the spine in this examinee. And I believe this case will be very illustrative of the many different ways and the many different applications that we have available to us for this particular and specific impairment, that is, impairment due to loss of motion segment integrity of the spine. And this represents a significant impairment of the spine. When the individual spinal segments lose their integrity for motion, it represents a significant source of pain, a significant source of weakness, a significant source of altered movement mechanics of the spine. So the AMA guides provide for generous permanent impairment ratings in the presence of loss of motion segment integrity. And just to reiterate what I've emphasized in earlier programs, I encourage you to adopt this procedure with every single spinal case. And I'll elaborate more on that as we go through today's program. Now, before we get into today's material, I just want to reiterate where we've come so far. In session 1 of this program, we talked about the AMA guides and specific references out of Chapter 15 of the AMA guides to get all on the same page as to what the AMA guides say about the analysis of motion segment integrity. And then in part 2 of this program, we went through a cervical spine case, an actual case from my archive library, wherein I provided for permanent impairment due to loss of motion segment integrity of the cervical spine. And we went through all of the measurements on the computer screen. I demonstrated exactly how to do the measurements for angular motion. And then in a subsequent session after that, we went through the permanent impairment and apportionment arguments in that case. So we did the analysis, we did the calculations to determine whether indeed there was normal intersegmental motion or abnormal intersegmental motion, and then we went through the thought process as to determining, okay, how now that we have this data, how does this data apply to permanent impairment, and how does the data apply to the apportionment of the permanent impairment? And I think that was a very creative and illustrative example for the cervical spine. Now today, what I have for you is a fascinating case of the lumbar spine. And this involves a 59-year-old female. She was a certified nursing assistant working in a skilled nursing care facility. So these are working with sick elderly people, not ambulatory social centers, which we have nowadays. But this was a skilled nursing facility center where the elderly patients were sick and required skilled care. Well, ordinarily, this certified nursing assistant works the night shift, and by the time she gets into work, all of the patients or residents are already in bed, and then she simply has to monitor them throughout the night until the day shift comes when the real activity ramps up. But on this particular day, she was called in early due to a short staffing situation, and she was required to help assist get residents into bed. Well, she's 5'3" 180 pounds with a waist circumference of 44 inches and a body mass index of 31.9. Now, body mass index greater than 30 qualifies as obese. So this female, 59-year-old female, was not your tip-top athlete, so to say. She was somewhat deconditioned around the midsection and probably quite weak in the lumbar spine and in the supportive abdominal musculature. Well, in the course of assisting a patient transfer from the chair to the bed, the patients are supposed to assist in the transfer by grabbing a support pole that's near the bed. Well, on this particular transfer, the patient let go of the support pole, and the weight of the patient unexpectedly came down upon the examinee, the applicant, the injured worker, in this case, 59-year-old female. And as the weight came down unexpectedly on her, she twisted, and they both sort of awkwardly stumbled, but they did not hit the floor. Neither of them hit the floor, so the resident was not injured, but the injured worker felt a sharp pain in the lumbar spine. Well, as she caught the weight of the person and regathered or regained control of the situation, she went to transfer the resident to the bed, and the bed apparently was not secured, and the bed moved slightly, and again she was required to forcibly contract the lumbar spine and forcibly load the lumbar spine. She felt again another sharp pain. Well, after getting the resident situated, she continued working, and then later on the same evening performed another patient transfer, and this time pain in the lumbar spine worsened, and she requested medical care the very next day. So she received medical care, and she was on total temporary disability for a period of approximately 15 months. 15 months. She never did return back to work after the date of injury. She never went back to work. She simply received medical treatment and followed home recommendations. Well, by the time of the qualified medical evaluation, approximately 15 to 18 months had passed, and she had not had any treatment for approximately 3 months because she relocated from one part of the state to another part of the state, and she had yet to secure or obtain a new primary treating physician. So I evaluated her, and she had bona fide objective physical exam findings for loss of range of motion, weakness on various orthopedic tests, but all examination maneuvers were negative for radiculopathy. So where does this leave us? This leaves us with permanent impairments due to the range of motion method, or permanent impairments due to the DRE method, no higher than the DRE2 because of absence of bona fide radiculopathy. So as in every single spinal case, I went through the process of ordering the flexion and extension radiographs, and let's take a look at those radiographs now. Okay, so here we are at the X-ray images, and I have the AP lumbar here in front of us, and you'll notice that this particular set of X-rays has a different interface than the X-rays that we reviewed with regards to the cervical spine. And that's okay, because all of the imaging facilities have their own proprietary software that they use, but basically they're all the same. They all allow us opportunity to use measuring tools, zoom tools, panning tools. And so even though it's a little bit different, once you learn how to use one imaging software, the rest become pretty much intuitive. So let's take a look at a couple things. Let's just zoom in on this X-ray. This is a A to P lumbar spine X-ray, and you'll notice that she has 5 lumbar spine vertebrae. There's an area of degenerative change between L2, L3, and the remainder of the lumbar spine vertebrae appear to be roughly within normal limits. Let's look at the L5S1 spot shot. You can see that this is the left, this is the right. The L4, L5 disc space is preserved. Can't really tell much about the L5, S1 disc space. Iliac crest and sacral ala are roughly level, so those are all good findings. We have a couple of obliques. Those fail to show any form of spondylolisthesis and or spondylolysis. So let's go to the lateral lumbar. And you'll notice the lateral lumbar has decent lordosis. Disc spaces are mostly preserved. There's some evidence of that degenerative change on the anterior superior end plate here of L2. Otherwise, disc spaces are mostly preserved, with the exception of the L5 S1 disc space here, which appears to be narrowed with some osteophytosis posteriorly and then perhaps also some anteriorly. So a good lumbar lordosis, fairly preserved lumbar spine disc spaces, with some diminution of disc spaces at a couple levels and some evidence of degenerative change at a couple of levels as well. So let's go to the flexion and extension radiographs. Here's the flexion. This is flexion and this is extension. So let's go to the flexion and take a look at the flexion images. And let's do our analysis of motion segment integrity. I'm getting out a piece of paper to write these numbers down. Okay, so let's begin. To do the analysis of motion segment integrity of the lumbar spine, we begin at the superior end plate of L1, which is right here. This is 1, 2, 3, 4, and L5. So we're going to begin up here at the superior end plate, and we're going to use our measuring tool to measure the Cobb angle. And we're going to draw a line across the superior end plate of L1 and a line across the superior end plate of L2. And we measure the angle. Now, notice that these lines here in the back, they would converge eventually at some point back here, while these lines in the front of the vertebrae are diverging. So we're going to name this a -2 degree angle. Lordosis angles are negative angles. In this lumbar position of L1 in relation to L2 are in lordosis. Okay? Now let's continue. Our next Cobb angle, which is B, we're going to draw a line across the superior end plate of L2, another line across the superior end plate, of L2 and L3. Here we get a -8 degree angle. Okay, a line across the superior end plate of L4, line across superior end plate of L3 for -16 degree angle. There's L5, again L4, -8 degree angle. So notice that at nowhere in the lumbar spine do any of the lumbar spine vertebrae flex. Now you may see some flexion angles in your examinee. The reason that this examinee is not able to achieve a positive flexion angle is because of limitation to range of motion. Okay, and finally, let's get the L5S1 angle as follows. And I love these digital tools because they're so precise and so pinpoint. And the software does the measuring of the angles for you. Okay, so that's -2 degrees, -8 degrees, minus 16 degrees, minus 8 degrees, minus 19 degrees. And let's go to the extension angles. And this is L2, 3, I'm sorry, 5, 4, 3, 2, 1. So let's measure our angles. This is a minus 7 degrees. This is minus 6 degrees. Here we have a greater angle, I can tell, minus 19 degrees. So that's an increase in motion at this level. L4, L405 angle. Minus 14 degrees, not quite as much motion there. And then finally L5S1, and let's really zoom in on that. Angle is right here. At minus 23 degrees. Okay, so we have minus 7, minus 6, minus 19, minus 14, minus 23. Okay, so let's now go to our analysis and plug these numbers into our formula and see how that impacts our decision as to the integrity of these individual motion segments. Okay, so now let's take a look at the report of findings of these x-rays as it appears in the QME report. So just to review, we create an entirely new section in our QME report entitled Diagnostic Studies, and here's where you want to include the findings of all of the diagnostic studies that have been obtained up to the date and time of your evaluation. So, for example, here are the findings of some prior MRI studies. And in this case, that's basically it. And then on the date of this evaluation, I referred her for updated x-rays of the lumbar spine. So those are what we're going to review right now. And this is a good phrase that you can include in your QME report. And your templated phraseology would look like this. In order to obtain Mrs. Jones' current condition, I referred her to a local imaging facility for updated x-rays of the lumbar spine. Those were completed on such and such a day. The report of findings, as described by medical radiologists, would go right here. And here is where you provide those findings. Now you also want to review those images yourself. So your template would go something like this. My interpretation, and insert your name right here so the parties are clear on who it is being referred to here in this section. And then provide your own analysis and your own report of findings of the x-ray studies. And if you have any agreement or any disagreement with the medical radiologist, indicate that here in this section of the report. And it's okay to have agreements or disagreements. I recently had a case that involved a anomalous cervical rib. And the report of findings, which went here from the medical radiologist, did not describe the presence of a cervical rib, but I was convinced that there was a definite cervical rib on many of the x-ray studies that I had in the file. So I called the medical radiologist back up and asked him to take another look at the images and to tell me whether or not, in his opinion, he identified a cervical rib, and he did. He agreed, and he provided an addendum to the X-ray report. So always, always, always provide your own interpretation of the X-ray studies. That way, should the case ever come to deposition, if you're ever asked by either one of the attorneys, doctor, did you yourself personally review the X-ray studies? Then you can confidently say, yes, that you did, as opposed to the opposite, which is quite embarrassing, which is, no, I did not review the studies. I simply relied on the report of the medical radiologist. You do not want to do this. You want to personally take responsibility for the images and for the case itself. So always, always, always review all images yourself. And just to demonstrate another example of that, with regards to this MRI study that was taken on 8/18/15, I called the examinee prior to my evaluation with the examinee and asked her to please bring a CD copy of this disc to our evaluation, and she did. She brought in a CD disc of the MRI studies. I then reviewed these studies. There was 179 images, and I reviewed each of these images. And even if I didn't have anything significant to add to the findings of the medical radiologist, I indicate here to the reader that I adopted the findings of the medical radiologist, and I provided a few additional findings that I felt that I was qualified as a chiropractor to be able to comment upon. So in the case of a shoulder MRI, or in the case of an elbow MRI, or in the case of a knee MRI, you may not feel qualified to comment on the MRI studies, but still review the images, review the anatomy, and if you have nothing further to add to the information base above and beyond that which the medical radiologist has reported, you can simply say that you adopt the findings of the medical radiologist. Okay? So there's a couple of suggestions as to how to format the Diagnostic Studies section of your report. But let's now go to our analysis of motion segment integrity. And here we have our values. Our flexion angular motion values are here. Our extension angular motion values are here. And here is where we do our calculation using the formula flexion angle minus the extension angle gives us total angular motion. So at L1 and L2 we had minus 3 degrees of flexion angular motion. We had minus 10 degrees of extension angular motion. And if you do the math, minus 3 degrees minus 10 degrees, we see that the spine is moving throughout an arc of, well, we see that L1, L2 is moving through an arc of 7 degrees of range of motion as the spine goes from the extreme of flexion all the way through to the extreme of extension. Now the AMA guides tell us on page 378 how much motion is normal for the L1 to L2 vertebra. It says in the lumbar spine there's a gradual increase in flexion extension movements from about 12 degrees at L1 to L2 to 20 degrees at the L5 to S1 level. So here we could reasonably expect about 12 degrees of total angular motion. So based on this description from the AMA guides, at least at L1, L2, that segment of the spine demonstrates decreased intersegmental motion. Okay, same calculation for L2, L3. We have minus 5 flexion, minus 9 extension. That is a total angular motion of only 12 degrees, and that represents decreased angular motion. Now, based on this reference from the AMA guides, a gradual increase from about 12 degrees beginning at L1, L2 tells us that at L2, L3 we should expect about 12 degrees of angular motion, 13 degrees of angular motion, 14 degrees, somewhere between 12 and 20 with a gradual increase. So 12, 13, 14, something like that. Well, 4 degrees is almost certainly decreased and is consistent with the AMA guide's description of, quote, complete loss or near complete loss of intersegmental motion. So 4 degrees represents not a complete loss, but it certainly is a near complete loss, almost showing very little motion throughout the extreme of flexion all the way through to the extreme of extension. That represents very little motion. Now, interestingly, at the next segment, L3, L4, we have minus 17 degrees of flexion angular motion, and the spine then moves through some movement to end up at minus 16 degrees of extension angular motion. Now, we would expect that as the spine goes from the extreme of flexion to the extreme of extension, the negative lordosis angle of minus 17 degrees here, this is a negative lordosis angle, we would expect that to become increasingly negative as the L3 and L4 vertebrae go into greater positions of extension. Well, our extension angular motion measurement ends up at minus 16 degrees. So we see that actually as those vertebrae go from flexion to extension, the vertebrae move in the opposite direction. In other words, they move in a position of flexion. They move in 1 degree of flexion. Now, this is what is known as aberrant or opposite motion, because we would expect those vertebrae to move into increasingly negative lordosis angles, increasingly negative extension positions. But we're seeing the vertebrae flex, and that is aberrant or opposite motion. Now, what if we mismeasured this this minus 16 degree angle? What if that was a mismeasurement and instead we came in at minus 17 degrees? Well, certainly that would then represent 0 degrees of angular motion, consistent with the AMA guide's description of complete loss or near complete loss of angular motion. So we know that this is an area where there's almost no motion. So the conclusion is for either decreased intersegmental motion, or in this case with a finding of minus 16 degrees, that is a finding for opposite or aberrant motion. And in either case, that represents a significant loss of motion segment integrity. Okay? At L4, L5, we have minus 7 moving into minus 15. That's a total angular motion of 8 degrees. Again, representative of decreased angular motion, because we should be moving towards 20 degrees at these lower levels. And then at L5, S1, we have another example where the vertebrae are flexing rather than extending and giving us lower negative values on extension than we see on flexion, resulting in 3 degrees of aberrant or opposite motion. Now again, what if we miscalculated or misdrew our angular lines? This number could come in close to 0, possibly depending upon how the measurements are done. Again, consistent with the AMA guide's description of complete loss or near complete loss of angular motion. So again, representative of significant loss of motion in segment integrity. So we have all of our findings. We have our conclusions over here. Now we have to decide, what do these conclusions mean? Do they mean anything at all? Do they contribute to the body of our opinions and conclusions, or are they simply coincidental findings without clinical significance? Well, let's just complete this section here and indicate to the reader that one of the conclusions is that based on the description from the AMA guides, Mrs. Brown has decreased spinal intersegmental motion at L2, L3, L1, L2, L2, L3, skips a segment at L3, L4, and L4-L5, while at L3-L4 and L4-L5 she has aberrant or opposite motion, and this aberrant or opposite motion is a sign of spinal segmental instability. Now again, if we measured these angles differently and came up with 0 degrees of angular motion at both levels, rather than aberrant or opposite motion conclusions, we would simply conclude that she had decreased spinal motion at all of the above spinal segments. So the impressions are that the lumbar spine x-rays are significant for age-related degenerative changes throughout, most pronounced at L2, L3, and L5-S1. Degenerative change is manifest as decreased disc spacing at L5-S1 and at osteophytes at L2, L3, and to a lesser extent at L5 and S1. The range of motion of the lumbar spine is reduced throughout with instability and aberrant opposite motion noted at L3, L4, and L5, S1. Now, because of these findings, I concluded that the L3, L4, and L5, S1 segments of the spine were the more or most symptomatic of the levels of the lumbar spine. And it's these levels that provide the basis for my opinion and conclusion on permanent impairment. And we'll go through the permanent impairment discussion and the apportionment discussion in our very next session. But for now, just remember that I consider these two spinal segments to be symptomatic. I did not consider the entire lumbar spine, even though it shows globally decreased intersegmental motion. I didn't consider the entire spine consistent with loss of motion segment integrity, but rather I limited my conclusion for loss of motion segment integrity to the two spinal levels that actually showed either complete loss of motion or aberrant or opposite motion at both of these levels. And I'll show you in our very next session how I provided for permanent impairment for that by using an alternative impairment rating. Okay, so doctors, that's very interesting. Would you agree? So drawing the measurements on the lumbar spine radiographs is quick and easy with the modern software packages that our local imaging facilities are using. Now, each facility uses its own proprietary type of software, but they all have the same basic features that include measuring tools that are very simple, quick, and easy for us to use in doing our analysis. And as I've stated in other video broadcasts and video discussions, obtaining the images in the first place is the major challenge that you're going to face. And after you've done this 2 to 3 to 5 to 10 times, the procedure will come exceedingly quicker and exceedingly easier. Now, in the beginning, it is going to be difficult, and I've had many doctors simply abort the procedure because for a variety of reasons, they simply cannot get the x-rays done, or they cannot get the images on their screen, or they cannot learn the software in time to produce their report within the 30-day timeline. But I want to encourage you to stick with it, stick with it, stick with it, because over time, very quickly, you'll become masterful and adept at manipulating the various pitfalls that attempt to thwart this procedure. I believe that this procedure, the analysis of motion segment integrity, is extremely valuable. It's extremely valuable for the examinee because it provides you clinical information about their condition that can be obtained no other way. We cannot get this information from the physical examination, and in fact, the physical examination can give us false negative impression of the examinee's condition. So I really, really like the analysis of motion segment integrity. So we simply obtain the measurements, we do the calculations, and then once we have the calculations, that's where we need to put on our thinking caps and decide what is the significance of a finding of decreased intersegmental motion, or what is the significance of a finding for increased intersegmental motion, or Perhaps is there significance even to a finding of normal motion? So it's at that point where we get to exercise our expertise, our skill, and our clinical judgment in arriving at our opinions and conclusions for, number one, permanent impairment, and then number two, the apportionment of any permanent impairment that we provide. Now, in our very next session, we're going to continue this case example, this exact specific case, and I'm going to show you the opinions and conclusions that I provided. And just to give you a little heads up on that, I provide for loss of motion segment integrity for 2 levels of the spine using an alternative Alvarez and Guzman rating method to provide for 40% whole person impairment. Now, this is unique and different from the way it's described in the DRE method, and it's different and more creative than what is described in the range of motion method, both of which would provide for no more than approximately 25 to 26% whole person impairment. And by using an alternative rating for multi-level loss of motion segment integrity, I was able to provide for 40% whole person impairment, and to make that opinion and conclusion qualify as substantial medical evidence. So I want you to make sure to not miss that session that's coming up in our very next session. So doctors, I hope this helps you, and I hope you enjoyed this presentation, and I hope you're impressed that the procedure, once you get it going, is actually quite simple and quite easy. So this is Dr. Perry Carpenter. It's been my pleasure to be with you here today, and I look forward to being with you on future sessions as well. And for now, I'm wishing you best success as a qualified medical evaluator.